So this lecture is going to look at glaucoma. Here's the learning objectives. There's only a handful, not too bad. These are the drugs that we can use to treat glaucoma. We're looking at beta blockers, alpha-2 agonists, cholinergics, such as pilocarpine and physostigmine, acetylcholinesterase inhibitors, such as ethylthiophate, carbonic anhydrous inhibitors, and there is some evidence to show that marijuana can lower intraocular pressure, but these are often used as a self-medication therapy in states that already have legalized marijuana. They're not, at this moment, they're not prescribed. So for open-angle glaucoma, where the drainage canals are clogged, causing an increased pressure, there are two mechanisms by which the intraocular pressure can be reduced. One, by reducing the secretion of the aqueous humor, and second, by enhancing its outflow or drainage. This can be achieved by all of the classes of drugs that are listed in the last slide. For acute closed-angle glaucoma, where the architecture of the eye is abnormal, causing the blockage, and increases in the intraocular pressure, the outcome remains the same. We want to reduce the intraocular pressure and cause any dilation, which would inhibit this outcome. Therefore, the medications are limited. Cholinergic drugs, such as pilocarpine or physostigmine, as well as acetazolamide, will allow for the induction of meiosis to relieve some of this intraocular pressure. Here's a table putting the clinical outcome associated with the drugs that are used in the treatment of glaucoma together. So basically what you're looking at is whether or not the drug enhances secretion or if it increases the outflow. So whether or not a drug reduces secretion of the aqueous humor or enhances the outflow. I said that backwards. And so this is just kind of a nice summary table. So beta blockers lower intraocular pressure by suppressing aqueous humor production. They inhibit the synthesis of cyclic AMP within the ciliary epithelium, and this leads to a reduction in the aqueous humor secretion. Timolol, levobunolol, and metoprolol, I can never say that one, are all non-specific beta blockers and bind to both beta 1 and beta 2. Betaxol is a relatively beta 1 specific, and cartidolol is a non-specific blocker with intrinsic sympathomimetic activity. Okay, I do want to point out that all these drugs are given either daily or twice daily, but do have systemic absorption. Even though they might be administered into the eye, systemic side effects can occur, and these can be more severe, affecting either cardiovascular, respiration, or central nervous system. Alpha agonists can be broken into two categories, either non-selective or selective. The non-selective alpha agonists include epinephrine, which we've already talked about, and can activate both alpha and beta receptors. The beta receptor effect would dominate, leading to an increased aqueous humor outflow. Epinephrine's mydriatic effect, however, renders it unsuitable for closed-angle glaucoma due to the further narrowing of the uveoscleral outflow. Dipivefrin, which is a prodrug of epinephrine, must be biotransformed into its active form. It can reduce intraocular pressure when given topically, but may also have adverse effects including burning, mydriasis, maculopathy, corneal endothelial damage, ocular hypoxia, and a few others. These side effects may hinder a patient from using this drug. Both aproclonidine and brimonidine reduce aqueous humor production. These are derivatives of clonidine. They are selective for alpha-2, of course, and combine both pre- and postsynaptic alpha-2 receptors. By binding to the presynaptic receptors, the drugs reduce the amount of neurotransmitter release through a process of negative feedback inhibition we already talked about in the previous block. This may have some effect on outflow as well. By binding to postsynaptic receptors, however, the drugs stimulate the GI protein pathway, the G protein coupled receptor through GI inhibitor G proteins, and that's going to reduce cyclic AMP production. that'll reduce aqueous humor production, and then all of these alpha agonists are given topically, of course. Side effects of alpha-2 agonists include mydriasis, conjunctival blanching, and contact dermatitis. If given systemically, of course, these drugs are much more profound. Cholinomimetics can also be broken into two groups, either direct-acting or indirect-acting. The direct-acting cholinomimetic, pilocarpine and carbachol, directly activate the muscarinic receptors within the eye. The indirect-acting physostigmine and ecothiopate reduce the degradation of acetylcholine by inhibiting the acetylcholinesterase enzyme. Activation of the muscarinic receptor by either an agonist or acetylcholine leads to muscle contraction, opening of the trabecular meshwork, resulting in an increased outflow of the aqueous humor. The cholinomimetics are available as topical agents typically. Pilocarpine is formulated as a solution, an ocular insert, or a hydrophilic polymer gel. Carbachol is a potent direct-acting miotic agent. Its duration of activity is longer than that of pilocarpine, somewhere in the realm of 8 to 10 hours, and because of resistance to hydrolysis by cholinesterase. Patients with an inadequate response to or an intolerance of pilocarpine as a result of ocular irritation or allergy frequently do well on carbachol. Cholinergic agonists have fewer systemic effects than beta blockers, but ocular side effects such as fixed small pupils or myopia, as well as increased subjective visual disturbances related to a coexistent or underlying cataract, have decreased the popularity of these drugs immensely. Also, cholinergics can be broken down into the blood and may result in a worsening of an ocular inflammatory reaction or inflammatory conditions. Prostaglandins, or PGF2, and their analogs, which are basically prodrugs, bind to the FP receptors that link GQ-coupled receptors to the phospholipase IP3 calcium pathway. Excuse me. This pathway is active, and in isolated human ciliary cells results in a remodeling of the extracellular matrix in and around the ciliary muscle, and this causes an increased uveoscleral outflow. Prostaglandins are generally considered first-line therapy. Beta blockers may be more appropriate as initial therapy for those patients who cannot afford a topical prostaglandin. They're a little bit pricier. In addition to conjunctival hyperemia, ocular side effects associated with prostaglandin treatment include eye irritation, increase in the number and the length of eyelashes, which in some people could be a good thing, and changes in iris and lash pigmentation. The latter two are most notable only if one eye is treated. Local irritation, such as itching and dryness, may be due to corneal irritation from benzalkonium chloride, which is often used as a preservative in several of these preparations. Carbonic anhydrase inhibitors, primarily those that inhibit isoenzyme type 2, are found on the ciliary epithelium of the eye, and it's involved in the secretion of solutes such as sodium and bicarbonate. By reducing the production of bicarbonate and by inhibiting the enzyme for its production, the amount of aqueous humor produced would be reduced or diminished. Systemic carbonic anhydrase inhibitors such as methimazole, even acetazolamide, have largely been replaced by newer topical preparations that have fewer systemic side effects. Topical carbonic anhydrase inhibitors do not appear to be as effective in treating open-angle glaucoma compared to the other drugs that are available and are now considered third-line therapy. Here's a nice diagram outlining the treatment regimen for a glaucoma patient. First-line therapy is a beta blocker or prostaglandin, with preference of prostaglandins if it's not cost prohibitive. Second-line therapy include alpha agonists and cholinomimetics, followed by third-line therapies, the carbonic anhydrase inhibitors. Combination products are now becoming more available for several classes of these drugs, where you can see something like a carbonic anhydrase inhibitor combined with an alpha agonist combined with a beta blocker combined with a carbonic anhydrase inhibitor, and so on. Some of these combinations are not used as initial treatment, but for patients requiring treatment with multiple drugs, as they offer different conveniences and cost advantages. Combination products containing prostaglandins are becoming available in Canada, but not in the United States as of yet. Of course, marijuana can reduce intraocular pressure, but only for short periods of time, which is really not why this drug is as useful as it could be. Of course, during that period of time, the patient is unable to drive, operate machinery, or do anything remotely useful besides raid the bakery section at Jewel. Perhaps there are better alternatives, and derivatives may be coming through the pipeline, but this obviously needs more research. Non-pharmacological methods include trabeculoscopy, which is essentially just a laser surgery where you widen the canal of Schem, and this increases the fluid drainage from the eye. Of course, this was invented by Dr. Evil. Another non-pharmacological method includes the addition of a stent, and this will assist in lowering intraocular pressure substantially and relieve the fluid buildup. So that's it for glaucoma. Please email me if you have any questions. Thank you.